All right. Well, good afternoon, everyone, at least everyone on the East Coast. Excited to have today's webinar focus on sickle cell disease and unmet needs in sickle cell disease as we're at the end of Sickle Cell Disease Awareness Month. Our very own, well, our former very own expert in this space, Dr. Latasha Lee, a former NMQF VP who's now at Vertex and is a 40 under 40, and I a class agent for her class. So the 40 under 40 will lead the call. So she's the expert I always go to on the disease and the therapy. So we figure we'll have her and one of her colleagues explain everything to us. So without further ado, Dr. Lee.
Thank you, Brandon. And I am going to share screen, so bear with me, everyone. It is so great to be back with the NMQF family. And I'm always around, just not necessarily on these calls. So it's great to see those of you out there. So good afternoon, and thank you again for joining us for this very informative and timely NMQF Friday webinar series. It's a very special time of year as many of us in the community join to recognize National Sickle Cell Awareness Month and the power and resilience of the sickle cell community. For those of you not familiar, September is National Sickle Cell Awareness Month. That is a time to recognize the perseverance of patients living with sickle cell disease. We often call them warriors because of all of the challenges that Dr. Badamosi will highlight today, and recommit ourselves to improving the quality of life and health outcomes of individuals living with sickle cell disease. It is a month that was designated by Congress to help focus attention on the need for research and treatment of sickle cell disease. Now, speaking of Congress, as a former staff person on the Hill, I must really take the time because it's exciting to see the level of continued political support from members, especially of the Congressional Black Caucus, who have really highlighted and continue to raise issues facing this community. The CBC has kept issues important to the community top of mind for the Biden administration, particularly for Secretary Becerra, who is the Secretary of Health and Human Services. Just this week, over 40 members of the CBC, led by Representatives Plaskett and Kelly, once again urged the Secretary to continue the administration's efforts to ensure all sickle cell patients have access to the care that will allow them to live long and healthy lives, including access to treatments as they are approved. So I want to thank Representatives Plaskett and Kelly for all those members of Congress who continue to fight for the improved care and outcomes for sickle cell warriors. Before delivering and delving into our presentation today, I want to introduce those of you who are unfamiliar with Vertex Pharmaceuticals. So with that, hopefully my slides are advancing. So Vertex Pharmaceuticals is a biotechnology company based in Boston, Massachusetts. We invest in scientific innovation really focused on serious diseases. So a few of the things that are unique to our company, but unique to many, are that patients, particularly at our company, are center and at the heart of everything we do. And we strike at the core of serious diseases in an effort to change people's lives. And we're really not afraid of taking on the impossible. One of our little bylines is for the lives that we have changed and for those who are still waiting, we will not stop fighting until we find cures for the diseases that we work in. We are kind of centralized around our values. Our values in our culture have been one of what our CEO, Dr. Reshma Keller Rami, states is the key driver to our success and the reason why we are so productive, collaborative, inclusive, and why it's so rewarding to work at Vertex. We call ourselves Vertexians, and we have an uncompromising commitment to patients. We really value we wins. We go in together to address many of the challenges. We have a fearless pursuit of excellence, and innovation is in our lifeblood. We have two programs that I focus on. So I didn't even introduce myself since Brandon introduced me. I serve as Director of Policy and Alliance Development and lead our patient advocacy in our hematology portfolio. And our Heme program is focused on sickle cell disease and beta thalassemia. to hereditary blood disorders affecting many communities of color. Today, we will focus most of our conversation on sickle cell disease, which we know is really highlighted by severe pain, organ damage, shortened lifespan, just interestingly, due to these misshapen blood cells, which Dr. Badamosi will go into. And our approach is looking at both gene editing, conditioning regimens, and small molecule approaches. Kind of a cousin to sickle cell disease is beta thalassemia. We will not focus on that for today. And we really do a lot of work. So my advocacy piece is really focused on engaging with the community by listening, doing education like today's webinar, supporting and providing access. So we are committed to these disease areas we work in. With that, I am very honored to introduce our speaker today, Dr. Nnenna Badamosi, who serves as an MSL Associate Medical Director at Vertex Pharmaceuticals. She is a pediatric hematologist-oncologist with clinical and research interest in sickle cell disease and hemoglobinopathies, and we joined Vertex in the same year, 2021. Prior to joining Vertex, she directed the Sickle Cell Transition Program at Augusta University and has remained focused on the global burden of hemoglobinopathies and improving clinical outcomes for children and young adults with blood disorders. When not working, she enjoys reading, gardening, including the plants we chatted about earlier, and spending time with her family. Her presentation today will explore the unmet needs faced by individuals with sickle cell disease and the impact this disease has had on their lives and the lives of their families. Take it away, Nnenna.
Thank you so much, Tasha. But thank you for the introduction, and it's a pleasure to be here. I am very excited to be sharing our educational session on the unmet needs in sickle cell disease. And as Tasha mentioned, I'm a pediatric hematologist. I'm a sickle cell physician primarily, and a strong physician advocate for patients and families with sickle cell disease. So clearly from my bio, sickle cell disease is near and dear to my heart. And as we round up Sickle Cell Awareness Month, it is such a pleasure to share and educate and inform all of us gathered here today. So I am going to share my slides. Let's see. Okay.
Really quickly, as she's bringing up her slides, for those of you tuned in today, feel free to put your questions in the Q&A box, and we'll address those throughout the presentation, but more formally at the end as well. But we would love to address them as we're coming to them on the slides.
Yes, absolutely. This is hopefully going to be an interactive session. I have a science-heavy slide today, and so I just want to make sure that no one fall, that we all stay engaged. So please feel free to ask me any questions as they come up. So I'm going to go ahead and delve into the unmet needs, medical needs of in sickle cell disease of patients and families with sickle cell disease. Today, I'm going to give an overview of the burden of disease. I will share the pathophysiology of sickle cell disease, and then I will delve into a little bit more detail about some specific complications around sickle cell disease and how they're managed, such as vaso-occlusive crises or VOC. I will talk about pain management, hemolysis and organ damage, red cell transfusions, and the like. And then I will summarize all of the information today. So please, while this is a lot of information, again, I'm open to questions during this presentation. Oh, excuse me. That just jumped all the way to the end. I apologize for the technical issue. I don't know how that happened. Well, before I talk about sickle cell disease morbidity and mortality, let's talk about what sickle cell disease is, right? So sickle cell disease is an inherited blood disorder. It is a disorder of red blood cells and a disorder that is caused by a mutation of hemoglobin. Hemoglobin is the oxygen carrying protein within red cells. The mutation that leads to sickle cell disease can cause red cell conformational change in times of stress. And so that conformational change inhibits the body's ability to carry that oxygen. The oxygen carrying capacity of red cells is limited. And these red cells have a shortened lifespan. So they undergo hemolysis before they're due to be taken care of by the system. So sickle cell disease can cause several complications. Anemia is one of them. Like we talked about, red cells are destroyed prematurely, and because of that conformational change, that doesn't allow for them to flow freely. Because they're not getting adequate oxygen delivery to their tissues, and because of some of the direct damage from the red cell products that break down, you can have multiple organ failure, you can have repeated tissue injury and damage. So all organs are affected in sickle cell disease: the heart, the lungs, the brain, everything that you can think of. And again, because of that conformational change, blood flow is interrupted within small blood vessels, especially. So you can see the hallmark manifestation of sickle cell disease, which is that pain presentation or vaso-occlusive crises. It manifests in several ways, either acutely as a severe acute pain episode, or even minor pain episodes, and then chronic pain that requires more complex management. Patients with sickle cell disease are also frequently in the hospital. For those of us who work in healthcare, in the emergency room, or inpatient stays, we know that our patients with sickle cell disease are frequently seen in the ED or in the hospital, either for pain, crisis, or related complications. And in terms of lifespan, patients with sickle cell disease have a much shortened lifespan when compared to national averages. 50, 60 years ago, sickle cell disease used to be considered a disease of childhood. The average life expectancy was about 14. And over the past 5 or 6 decades, that expectancy has improved, but not to the degree that we would like. So the life expectancy of patients and families, patients with sickle cell disease, is still somewhere in the mid 40s. And so that needs to change. When we refer to the vaso-occlusive crises or the acute pain crises, this is a typical hallmark of sickle cell disease that many patients will complain about. You can see the average annual number of vaso-occlusive crises that are reported globally. But when you see this number, I think it's an underrepresentation because it doesn't capture a lot of the minor pain crises that patients experience at home, or the pain crises that they choose to manage outside of a healthcare facility. So typically, this is an underestimate of the true prevalence of vaso-occlusive episodes. However, even with this underestimation, 90% of US adults will report that they've had at least one severe pain episode in the preceding 12 months. 20% of adults will report that they've had a pain episode in the past week even. And when we talk about emergency department visits or hospital admissions, you can see the burden of vaso-occlusive episodes and how frequently they present. And in spite of advances in treatment, sickle cell disease still is associated with a high mortality. So we talked about how over time, the median age of mortality has increased, but not to the degree that we would like for a disease as prevalent as this. And even though sickle cell disease is referred to as a rare disease, in the United States, it affects nearly 100,000 people, probably more. And globally, the burden of disease is very high in areas of sub-Saharan Africa, the Middle East, and Asia. So sickle cell disease is the least rare of the rare diseases, right? But looking at the mortality in high income countries where care is optimized, we still don't have optimal outcomes and we still have high mortality rates. So overall, you can see that in the US and Europe, mortality rates have overall improved slightly. And a lot of that is accounted for by improved mortality rates in children. So there have been several advances in care over the past several decades that have improved the mortality in children, which was primarily due to infections and things like that. Now that that mortality has decreased, we're starting to see higher mortality in patients 19 and older. So it's still a high burden of mortality. Now let's talk about the pathophysiology of sickle cell disease in more detail. Now, sickle cell disease is caused by a point mutation in the beta globin chain. The beta globin chain is responsible for creating one of the subunits of the hemoglobin molecule. The hemoglobin molecule has four subunits, two alpha and two beta. This mutation in the beta globin gene causes a slight conformational change. You can see that there's just a 1-point misread that changes the amino acid residue from glutamine to valine. And this tiny little misread or missense mutation means that every time red cells are exposed to stressors like deoxygenated states or even physical, emotional, and other different stressors, that the hemoglobin molecules will polymerize within the red cells and cause that sickling shape. This is the shape that is hard to flow through blood cells and is therefore hemolyzed or removed quickly from circulation. Like I said, the deoxygenation, under deoxygenated conditions, the sickling occurs, and that polymerization leads to hemolysis, vaso-occlusion, and chronic anemia. In terms of vaso-occlusion, the red cells interact with other cells within circulation, including the white blood cells and the platelets, to form these little microthrombi or micro-occlusive thrombi that disrupt the normal flow of blood to multiple organs. So anywhere you have blood flowing, essentially, you can have sickle cell damage, and more so in small little vessels. So think of the eyes. In children, think of smaller vessels like at the ends of their fingers or the ends of their toes. Anywhere that the vessels get smaller and smaller, you're prone to vaso-occlusion.
I think this is one that I want to just share a little anecdote from some of the patient feedback that I've received. So one of the sickle warriors shared, wherever blood flows, sickle goes. And that's so true, because people think, oh, it's only in this area. No, it affects the long bones. It affects the brain. You can have stroke. I mean, literally any part of the body where your blood flows, which is everywhere, sickle cell can have some form of impact, deleterious impact, from leg ulcers to more than you can even imagine. I think you actually have a slide that shows some of the manifestations of the disease.
That's absolutely true, Latasha. So even though we hear of pain, you have all of these silent infarcts and silent damage that happens in all of these other organs that is not always felt or immediately detected. So, we're talking about pain, first of all, and we'll go into all the other complications where, sickle complications arise. But talking about pain, these are some of the common areas that patients experience pain. It doesn't mean that they don't experience pain in all these other places, but you hear typically that they have pain in their arms, their thighs, lower back, hip, chest, knee. In the younger children, like we talked about, the hand and foot syndrome or dactylitis occurs because those vessels are so much smaller within the fingers and toes. And when we talk about triggers for vaso-occlusive episodes, many stressors can trigger that. So sometimes high altitude, where oxygen tension within the blood is low, or illness when fever or infection occurs. Dehydration is a common cause or trigger for vaso-occlusion. Mental and physical stress. A lot of patients will report that while they're getting ready for a test or while they're getting ready for an interview, that can trigger a pain crisis. And sometimes changes in weather. They say people with arthritis can predict when the weather is about to change. Sometimes with sickle cell disease too, you can see as summer becomes fall, there's an increase in the number of patients who present with pain or have painful episodes. And I want to talk about some more specific complications of sickle cell disease. So starting with the chest. Acute chest syndrome is essentially a vaso-occlusive episode in the chest, but it's a little bit more complex than that. It is a leading cause of death, especially in children with sickle cell disease. And if you think about the pathophysiology, if you think about what's happening where within the lung vasculature, the lungs that should be your oxygen engine, right? They should be giving your red cells oxygen to take to other parts of the body. But when your lungs themselves are starving of oxygen, you can imagine what's happening. So you're having vaso-occlusion within the lungs. You're having pain and fever, and it's sometimes preceded or triggered by an infection within the lungs. So especially in young children, if they have like a cold or a URI or a respiratory infection, there's a lot of pooling of blood within the lung vasculature. So you see acute drop in hemoglobin, you see increased hemolysis. Their oxygen saturations drop very quickly. They can start having infarcts, and if this is not interrupted quickly or managed quickly, it can lead to death. So many times the therapy or the management involves quick oxygen delivery, sometimes transfusions to give increased oxygen carrying capacity and help reverse that sickling vicious cycle and help prevent the infarction that occurs with vaso-occlusion. But it is a leading cause of death in sickle cell disease. Any questions so far?
I'm not seeing any, but I did see a comment around thalassemia. Can you talk just briefly about thalassemia and especially the link between co-inheritance of both from parents? So a parent with trait for thalassemia and a parent with trait for sickle, and what that would be for a child potentially.
Absolutely. So, we're referring specifically to beta thalassemia, right? So beta thalassemia is different from sickle because sickle is a qualitative defect in beta globin, whereas beta thalassemia is a quantitative defect in beta globin. So sometimes there's not necessarily a mutation where you have that conformational change. You may still be able to produce beta globin, but just in reduced quantities, or sometimes, depending on the mutation, not at all from that gene. And so in and of itself, it is when people inherit beta thalassemia on their own, like they have two parents who have the beta thalassemia gene and they're homozygous for a form of beta thalassemia. What happens is they're not able to have good oxygen carrying capacity. Many of them are transfusion dependent. But when that beta thalassemia gene is co-inherited with sickle, what it means is your primary functioning beta globin is only that sickle. And your beta thalassemia is basically an absence of beta globin production. So that sickle mutation is essentially doing all the work for both genes. So what that means is people with a form of sickle beta thalassemia called sickle beta 0 will manifest exactly like people who are homozygous for sickle cell, like have two copies of the sickle gene. And then people with a form of sickle beta thalassemia known as sickle beta plus are producing very reduced quantities of normal hemoglobin. And so the predominant hemoglobin within circulation is still sickle hemoglobin. So while they have some normal hemoglobin, like the same hemoglobin that other people with sickle cell trait or who don't have sickle cell at all carry, it's not enough to overcome the effects of sickle hemoglobin within the circulation. And so they're still symptomatic, just a little bit milder than those with hemoglobin SS. Does that make sense?
Thank you.
Okay. All right, so let's continue with some of the complications of sickle cell. We talked about acute chest here. Let's talk about some of the management options for pain crises. So we've known that for a long time, there haven't been a lot of therapeutic options for sickle cell disease in general. I remember as a trainee, the only option we had for hydroxyurea, and almost for 30, 40 years, was for sickle cell disease was hydroxyurea. Thankfully, over the past decade, that has started to change. We're starting to see a lot of therapeutic options, but this is still limited in the acute setting. So when we're talking about acute management of pain crises, many of these patients are in pain. We're not necessarily directly treating the cause of the pain, but we're trying to relieve the pain as a result of all of that sickling and vaso-occlusion. So you see the pain management, the pain relievers here, the non-steroidal anti-inflammatories, as well as opioids are used for pain management. IV fluids are generally typically recommended to help improve blood flow and improve some of that sickling, because we know dehydration can also worsen sickling. And oxygen therapy, again, these are just kind of adjunctive measures. We're not targeting what the underlying cause is. We're just helping improve oxygen carrying capacity because these cells are sick. Now, when we talk about chronic management, long-term management, how do we prevent these pain episodes from occurring again? Hydroxyurea is the mainstay of therapy that most hematologists have in their toolbox. There are issues with low adherence. However, it is one of the longest studied therapies for sickle cell disease. Some of the newer therapies on the market are L-glutamine and crizanlizumab. While L-glutamine is it's an oral therapy, so I guess it's easier to use. Crizanlizumab is an IV therapy that requires maybe monthly infusions, and so patients have to be plugged into a comprehensive center and be able to come and get those IV infusions for several hours. So there is that burden of IV administration as well as cost for some of these newer therapies. Regular transfusions are not always indicated for patients who frequently get vaso-occlusive crises, because now that we know more, the use of transfusions can sometimes lead to increased alloimmunization, especially in the acute setting when they're used acutely for a vaso-occlusive crisis. So they're usually reserved for life-threatening complications and for people who have chronic diseases that need to be managed, such as stroke. Another neurotherapy, voxelotor, has been approved in sickle cell disease for the treatment of anemia, but so far it has not been shown to be effective in preventing or reducing vaso-occlusive crisis burden. And you can see that while patients and hematologists alike are generally dissatisfied with the current pain options or the current treatment options for pain. Obviously, we don't have a lot of tools in our toolbox. Patients are dissatisfied when they go to the emergency room because they are easily labeled as drug seekers, because again, we're not treating the underlying cause of disease, we're giving them opioids. They turn around and become dependent on the opioids, and when they come back, then they're labeled as drug seekers. So it's a vicious cycle that causes a lot of disruption and stress for patients. But the patients perceive that acute pain treatment can lead to stigmatization by providers. They don't necessarily receive higher quality care. Patients perceive that providers are lacking sensitivity to the pain that they experience, especially when patients come in saying they're in a 10 out of 10 pain, and someone says, well, you don't look like you're in a 10 out of 10 pain, right? We all know some of the disparities around healthcare in minority groups, or even in our sickle cell patients, where they talk about they have to dress nicely to come to an ED, because if they come in looking a certain type of way, they may be mistreated or treated differently. So if they go out of their way to come to the ED looking like well taken care of, it turns around and can backfire, because someone says, well, if you took this much time to get ready, then you can't be in 10 out of 10 life-threatening pain. So these are
double-edged sword.
A double-edged sword, right?
Definitely. And then also I've heard individuals share that a lot of the tactics they learned in pediatric care, such as distraction therapy to get their mind off of their pain by playing video games or something else, is seen as, oh, you're just drug seeking, because if you were in that much pain, you wouldn't be on your phone, or you wouldn't be playing a game, or you wouldn't be on social media.
Right.
And so it's kind of a flip-flop.
It's a double-edged sword.
Yeah.
It's a double-edged sword. And you see these patients distracting themselves in the ED, or they're trying to manage themselves until it gets really bad. And then when it gets really bad, people say, why did you come in sooner? But people don't want to come in sooner because of the way they're perceived if they come in. So, you're like, patients feel like they can't win, and there's a lot of mistrust of the healthcare system. In addition, when they go to the ED, there's long wait times. There's not a lot of prioritization of the pain that patients are in, when that pain is actually causing ischemia and organ damage, just ongoing. But that is not prioritized because it's not seen maybe as a life-threatening event in that setting. Many patients are concerned that providers lack knowledge of the current guidelines. And then there's a real concern about addiction. It is possible to get addicted to these opioid medications as well. So these are just some of the concerns that patients experience.
Thank you for mentioning guidelines. I think this is an excellent opportunity that NMQF provides by letting us share this information to both providers who may be on the line as well as general public. I'll be placing in the chat the links to the current sickle guidelines that have been produced by the American Society of Hematology for those of you interested.
Thank you. So we know that as we begin to evolve in our management of patients with sickle cell disease, we know that when we individualize care, outcomes improve and we reduce healthcare costs. When patients are plugged into a comprehensive treatment center where we have a comprehensive pain plan for them in conjunction with their ED providers, where patients know beforehand or the providers know beforehand what kinds of therapies these patients should be getting. Their time the time they spend waiting in the emergency room decreases, the time they to opioid therapy or pain relieving therapy is decreased, and patients report overall improved satisfaction. Compared to when they do not have that comprehensive plug-in and when they are not following evidence-based guidelines. And so we'll move over into chronic pain in sickle cell disease. Now, chronic pain is a little bit more complex than acute pain. We've spent a little bit of time talking about these acute vaso-occlusive crises, but chronic pain is a little bit more complex. While acute pain contributes to chronic pain, there are underlying disease pathologies that can cause chronic pain. Over time, whether there's desensitization in the pain pathways or desensitization from increased opioid use, patients tend to have altered pain pathways that cause, that are just on all the time, and they can just continue to present with pain even when they don't seem to have an acute crisis. Underlying conditions such as leg ulcers and avascular necrosis, so this is where they've had long-standing damage within the bones, typically in the hip, but sometimes in the shoulder, can cause chronic pain. And also the psychosocial component of pain, influenced by mood, the effectiveness or lack thereof of acute pain management, all of these can contribute to chronic pain. There's not a lot of guidelines for therapy, and it's not a very well managed and well studied part of sickle cell disease. So that's another gap in care that needs to be addressed. So we're going to switch gears and talk about the anemia from sickle cell disease. I had mentioned that red cells that are sickled have a shortened lifespan. The normal red cell lifespan is anywhere from 90 to 120 days because sickle cell red cells have to be removed from circulation. That lifespan can be anywhere from 10 days to 20 days or even shorter. So the red cell damage that's caused by the sickling and membrane dysfunction in sickle cell disease can lead to hemolysis, both intravascularly and extravascularly. Now, intravascular hemolysis leads to the red cell contents being released into circulation, into plasma, and those can have additional downstream effects. Nitric oxide, which is a natural vasodilator within the endothelium or within the vasculature, is decreased when free hemoglobin is circulating. And so these patients have dysfunction, endothelial dysfunction, where their blood vessels are not able to naturally dilate in response to increased oxygen need. And then their extravascular space is overwhelmed very quickly by these red cells that are damaged. So their spleen over time gets overworked. Some of these patients have autosplenectomies. They have their spleens infarct over time because they have just continued to process these sickled red cells and continue to experience tissue damage. Now, intravascular hemolysis is an important driver of long-term vasculopathy and end organ failure. Free hemoglobin, like I said, leads to decreased nitrous oxide, but some of these are, you can see some of the markers of hemolysis that are seem to be elevated in sickle cell disease, such as bilirubin and lactate dehydrogenase. We talked about the fact that sickle cell disease affects all body organs. So some of the long-term complications they can experience include ischemic strokes in the brain, pulmonary hypertension within the pulmonary vasculature, hypertension, kidney disease, leg ulcers, and priapism, which is sustained unwanted erections that lead to can lead to eventual subfertility or fertility issues in male patients. When we talk about the burden of sickle cell disease on daily lives, you can see that patients report detrimental impacts in school achievement, reduction in work hours. There's a high impact on spousal or partner relationships. Many patients are unable to endure physical activity for a long time. And mood changes are an issue as well. Depression and anxiety have been reported in a good number of patients with sickle cell disease. And parents are also impacted when their children are living with sickle cell disease. So while the children themselves will experience pain, disability, decreased quality of life, parents can also experience loss of income every time they have to leave work to take their children to the ED or stay with them in the hospital. Mood disorders, depression, anxiety have been reported in parents as well. Again, not to over stress the fact that the clinical complications of sickle cell disease are myriad, but basically every organ can potentially be affected by sickle cell disease, and some of those specific complications are listed here.
So apologies, the question just came in. And is medical cannabis effective for pain management in sickle cell disease? Is one of the questions that came in.
So there are studies, I know, of investigators who are looking at cannabis and cannabinoids in patients with sickle cell disease. I know some investigators who are looking at mouse studies. I don't know that it's approved yet. I know people have reported anecdotal improvements with CBD oil, like rubbing CBD oil over areas where they have pain. I've had parents who do that for their patients, but it's not currently FDA approved for that indication. So the early manifestations of end organ damage with sickle cell have long-term consequences. Stroke and silent cerebral infarcts are associated with cognitive impairments in children and young adults in later life. Early kidney disease can lead to eventually proteinuria and kidney failure as they get older. Splenic damage or functional asplenia, also known as autosplenectomy, can disrupt immune function and eventually lead to increased risk of life-threatening infections. And endocrine dysfunction can lead to delayed growth, hypogonadism, and eventually insulin resistance in adults. When we talk about vasculopathy, so this is an encompassing term that describes the endothelial dysfunction, the inability of the vasculature to respond adequately to meet increased oxygen demands over time. That can have long-term complications in the heart, in the lungs, and increase the risk of death in patients and patients with sickle cell disease. We talk about increased vascular stasis leading to vaso-occlusion, and ischemia, reperfusion injury, and systemic inflammation. So all of these contribute to the pathophysiology of patients with sickle cell disease vasculopathy.
On the topic of some of those pathophysiology and manifestations of sickle, we have a question that came in. Can someone with sickle cell trait have some of the same effects, i.e. strokes, high blood pressure, or organ damage as an individual living with trait?
So that's a great question. So far, the only complication that has been described in increased frequency with patients or with people who have sickle cell trait is kidney, renal dysfunction. So certain renal complications may be seen in sickle cell trait in adults with sickle cell trait over time. There's a slightly increased prevalence of a certain kind of kidney malignancy or renal malignancy that may be seen in participants with sickle trait.
Renal medullary carcinoma. Mm-hmm.
Right. And that is believed to be due to the underlying sickling within the renal medulla. But other than that, there hasn't been any demonstrated relation with strokes or hypertension outside of the normal population. No.
Thank you.
When we look at transfusion management in patients with sickle cell disease, transfusions used to be the mainstay of therapy for many sickle complications. And over time, the field has moved away from that slowly. So like I talked about earlier, transfusions are only used for specific instances, things like that are potential life-threatening complications, either in the acute setting or in the chronic setting. So things like an aplastic crisis where the bone marrow has an infection and is no longer making any red cells. You will need a transfusion until that process improves. The hepatic or splenic sequestration can be acutely life-threatening, acute chest syndrome as well. And these require transfusions. A stroke as well, and in patients who are getting surgeries, the risk of anesthesia is associated with a high risk of stroke and acute chest syndrome. So it is recommended that patients prophylactically receive transfusions before receiving general anesthesia in order to prevent some of those life-threatening complications. When we talk about chronic transfusions, that's using transfusions, say, every month or every 3 weeks to prevent further complications. It is seen in the use of primary stroke prevention. That's patients who are high risk of stroke but haven't yet gotten a stroke, as well as secondary prevention of stroke. That's patients who have had their first stroke and are very high risk of getting a second stroke. Also, prevention of silent cerebral infarcts recurrence, as well as patients who have frequent acute chest syndrome and in complicated situations like pregnant patients. Patients with sickle cell disease may require transfusions that are either simple transfusions where they just receive that one-time red blood cell unit, or automated red cell exchange where several units are pooled together, and the sickle using an automated process where the sickle red cells are taken out of circulation and then non-sickle donor red cells are given. And usually with the automated red cell exchange, it's an apheresis machine that is used. Each of these has their advantages and disadvantages. Simple is easier to use in any kind of setting, whereas an automated red cell exchange requires more specialized staff and equipment, but does have a higher chance of effectively lowering the circulating sickle hemoglobin and leading to better outcomes. Automated red cell exchanges, both transfusion forms over time can contribute to iron overload, but the idea is that red cell exchanges will do that a little bit less because you're effectively taking out sickle red cells while you're giving donor red cells. And so the net iron exchange is hopefully zero. Transfusion-related complications are primarily alloimmunization, iron overload, and infection risk. Thankfully, with improved blood transfusion practices, the risk of transmission of bloodborne pathogens has decreased over time, but in low-resource settings, that continues to be an issue. Alloimmunization especially is a concerning problem in adults with sickle cell disease because over time, that repeated exposure to foreign antigens from donor red cells can increase your sensitization. And unfortunately, with alloimmunized patients, what ends up happening is they end up hemolyzing those donor red cells, right? So you lose the effect of a red cell, and it can lead to a potentially life-threatening complication.
On this topic of allo, really quickly, I know we say
Yeah.
blood is blood, but it is important to have minority donation of blood due to those antigens. And there's some very interesting programs. I'm here in the DC metro area. So for those of you in the mid-Atlantic, the American Red Cross has a program called the Blue Tag Program, specific for sickle cell disease, which really targets minority donors of blood so that those antigens can be reduced for individuals living with sickle cell to better match those individuals who receive frequent blood transfusions in sickle.
Absolutely. So we know that patients with sickle cell disease are some of the highest users of donated red cells. However, the highest number of donors are usually of European ancestry, and patients of African and African American ancestry tend to have more antigens on their red cells. So it's harder to find true matches for patients with sickle cell disease. So absolutely, be a red cell donor. Iron overload can cause long-term complications in the liver and heart, and chelation therapy is required as an additional step to help decrease the burden of iron. There's guidelines for iron chelation therapy in patients who have sickle cell disease and acquired iron overload. Iron chelation therapy can be costly. It can either be episodic or required routinely when patients are on routine transfusion protocols. But iron chelation therapy can have its own side effects. It is the dosing might be inconvenient. Sometimes it's IV, or it's huge pills that need to be taken 2 or 3 times a day. And so, the benefits of iron chelation therapy are usually offset by the burden of therapy.
Nnenna, there's a question, and I may be reading it wrong, so I'd rather you take a look at the Q&A.
Okay.
Can you discuss how our provider can address, is that enuresis, in adolescent and young adult patients with sickle cell disease?
So for patients who have enuresis, which is typically it's described as nighttime bedwetting or things like that. That's a common complication in sickle cell disease because the renal medulla, like we talked about, over time with that ischemic damage, it's not filtering properly. So while patients are encouraged to stay hydrated and drink lots of water, sometimes all of that water is filtered out very quickly. So patients, it's very common to see young adults or children who continue to have bedwetting episodes or unable to hold their pee. What I've typically done in practice is to screen for other underlying renal complications. So making sure that patients are not proteinuric or they don't have protein in their urine, making sure they don't have glucose in their urine, because these could be other exacerbating factors for enuresis. But eventually plugging them in with a nephrologist is a good idea. Nephrologists have more tools to manage enuresis outside of the sickle hematologist toolbox. Sometimes, they use non-pharmacologic, and sometimes they use pharmacologic means to manage enuresis, but keeping a close eye on that particular person, because they might be higher risk for eventual renal complications. And it's, usually just portends renal ischemia over time. Does that answer the question? I hope.
Hope so.
Okay, so, all right, so I have a few more slides discussing the complications. I want to talk about the current curative therapy for sickle cell disease. Allogeneic stem cell transplantation is the currently available FDA-approved cure for sickle cell disease. It's a complicated process requiring the harvesting of stem cells from a donor, and that ideally that donor should be matched on a molecular level with the recipient. That recipient is then given that stem cells after an episode of conditioning. They're receiving chemotherapy to get rid of their sickle producing stem cells, and then they receive the donor stem cells. Allogeneic stem cell transplantation is indicated when patients have a matched sibling donor. However, we know that fewer than 20% of patients with sickle cell disease have a matched sibling donor. So that curative therapy is not widely available to all patients with sickle cell disease. The highest success rates of allogeneic stem cell transplant are seen when the transplant occurs in younger patients. So matched sibling donor transplants tend to have higher overall survival and event-free survival when compared to less than ideal matches, like an unrelated match or a haploidentical match, which is usually like a parent or a sibling. You can see the outcomes of matched sibling donors, but higher survival occurs in patients who are less than 16 years of age. But again, the donor availability is limited with patients with sickle cell disease. I believe to date, less than 2,000 stem cell transplants have been performed in patients with sickle cell disease. Allogeneic stem cell transplant is associated with risks like end organ damage, drug toxicity from chemotherapy, including infertility, increased mortality. Immunity is compromised because patients will require long-term immunosuppression to prevent graft versus host disease or graft rejection. And because of that immune suppression, they're more prone to infections and potentially life-threatening infections. And so to summarize all that I've discussed today, I want to remind us that sickle cell disease is a life-threatening monogenic blood disorder that's caused by a single point mutation in the beta globin gene. And the homozygous expression of the sickle mutation leads to the formation of hemoglobin S. Under the oxygenated conditions, that hemoglobin S will polymerize and lead to a cycle of occlusion, hemolysis, vascular injury, endothelial dysfunction, pain crises, anemia, and end organ damage. Life expectancy of patients with sickle cell disease is in the 40s, almost 30 years lower than the general population. And sickle cell is associated with a significant burden on patients as well as the caregivers in terms of their physical, mental, and social well-being. While red cell transfusions may reduce, they do not eliminate chronic disease complications. And stem cell transplant, allogeneic stem cell transplant is a curative option for some patients with sickle cell disease. However, it is only available to a select few. And with that, I would like to thank you for listening, and I'm happy to take additional questions.
Thanks so much for that. The prior question around the bedwetting, they appreciate your comment around the referral to a specialist. One last question just came through. Can you please comment? Actually, apologies, I didn't read it ahead of time. Unfortunately, and I didn't mention this during our opening remarks. Our company is doing an investigational study into gene editing and gene therapy, and we're currently in FDA review. So unfortunately, we can't comment on that at this time. So we're unable to answer that particular question. If you have any other questions, feel free to put them in the Q&A or in chat. We'll leave it open for a few more minutes. Again, this is the last day. No, tomorrow's the last day of Sickle Cell Awareness Month. We really do thank you for attending today's webinar. I have put into the chat resources that honestly anyone can utilize if you are an advocate for a warrior, a parent of a sickle cell warrior, or a warrior yourself, or a physician or a nurse. I placed the guidelines produced by the American Society of Hematology that focus on cardiopulmonary and kidney disease, complications of sickle cell disease, cerebrovascular complications, management of acute and chronic pain, stem cell transplant, as well as transfusion. And then lastly, we heard challenges that individuals face in the emergency room settings. So there's also a resource inserted in the chat, focused on the American College of Emergency Physicians point of care toolkit that they produced on the management of sickle cell disease in the emergency department. It doesn't look like we have any more questions. So with that, I want to thank everyone. I'll turn it back over. Is Brandon still on, or Ashley, you have any closing remarks? If not, I'll close things out. So with that, thank you so much for tuning in today, and I hope to see you guys on another future webinar. Thank you.